outline here is we're going to talk about what is a flat foot. We're going to talk about shoes and orthotics. There were a lot of questions on shoes and orthotics. We're going to talk about what type of x-rays and MRIs to use, what type of bracing to use, and then any surgical treatment, and then answering some of the questions that you all may have. I'd like you to hold the topics till the end. Any questions you have that you can say them afterwards. So I'm going to introduce Dr. Kellner. He's going to talk a little bit about what is a flat foot.
Hi, everybody. Welcome. So let's get right into it. So just looking here at the picture, what is a flat foot? We have our 3 foot types, where we have the flat foot at the top, the normal foot, and the high arch. And you can easily see the difference there with the flat foot being, foot is fully in contact with the ground, which is abnormal, versus a normal foot, where you can see there's a little bit of a lift in the arch and in the ground contact picture there, and versus a high arch foot or a hollow foot, where you can just see straight through the bottom of the foot if there is that significant of an arch. Well, next slide. But there's a lot more to a flat foot than just arch collapse. The arch collapse is one component, but as you can see, there are actually 3 components here that should be addressed or evaluated for. Going by the middle picture there, that's looking at the position of the heel. Some of you may have heard of pronation. Certain levels of pronation are normal, but what becomes abnormal is when you're over pronator, and that's your heel. You can see as your heel turns outward. And then on the bottom picture, there's the 3rd component where your forefoot is turned outward, and you have that's what's called the too many toe sign or peekaboo toes, because when you're looking at the foot from the backside, you can actually see too many toes, more than you normally should. Next slide. But there's always more to a flat foot. That's the components and what characterizes a flat foot, but that we have to know the reasons why, so we're able to treat them appropriately. So we can go to the next slide here. And so there's at birth causes and adulthood causes. So you don't need to read through all of these, but just to see that there are many underlying reasons why we develop a flat foot, or we may start with it at birth. But next slide, we'll see that I'm going to focus on these 3, just to touch base on what I think are some of the more common causes of a flat foot. So next is tarsal coalition. What that is, it's an abnormal connection or union of 2 or more bones found. It starts at birth, and it's often an inherited condition. When you have a union, especially across a joint, it's like an abnormal fusion. You'll lose range of motion at that joint. And since we're born with mostly cartilage, as our bones develop into our, around 8 years old up to 16 years old, as cartilage becomes bone, that's when you'll actually see that some symptoms may present. So you won't see it right away at birth. But you might find like a teenager complaining of pain. They might have muscle spasms in their foot. That's related to the rigidity of the foot. So those are kind of the basics of tarsal coalition, and we'll kind of address maybe more treatments later. So next slide, I'll talk about equinus, which is a fancy medical word for calf tightness. Looking at the picture here, the calf muscles, the main 2 components are your gastrocnemius and soleus muscles. Those combine and form your Achilles tendon, which then inserts down onto your heel bone. And so these are the areas that we're focusing on when we say calf tightness. On the pictures on the right is kind of how we evaluate for this equinus or tightness, basically looking at the upward motion of the foot at the ankle joint level. And if there is too much tightness, you won't be able to get that foot dorsiflexed or extended up as high as it should go, at least. The next slide here will show how equinus can contribute to developing a flat foot. It is a pretty blurry picture. I got it from a study that I really like. So But basically on the left, you can see, a normal foot without equinus stepping forward, and the heel lifts up and the toes are planted on the ground, versus someone with very severe equinus. As their heel comes up off the ground, they don't have enough upward motion at the ankle, and therefore the joints in the midfoot will try and compensate, and you get kind of a bend at the bottom of the foot, and thereby that's how a flat foot can be caused by this equinus. And then lastly, just to touch upon posterior tibial tendon dysfunction. So this is what I consider to be the most common cause of an adult flat foot. It's most often seen in around middle age, people in your 40s or so. Various presentations of symptoms. When I say think progressive, means it gets worse as time goes on. So early intervention or early treatment is certainly advised. And weakness of this tendon is what leads to the deformity. So looking at the picture on the right here, you can see your posterior tibial tendon. It starts as a muscle that comes from your calf. As it traverses down kind of on the inside and behind the ankle, onto the bottom of the midfoot area, you can see as it's a main supporter of the arch of the foot. And as with time and many other factors, this tendon can weaken, and that's how you can get a midfoot arch collapse. And that's that.
Good. Now we're going to have a thank you, Dr. Kellner. We're going to talk now about shoes and kind of how a flat foot can be fit into a shoe, and then when an orthotic is going to be appropriate. There are a lot of really good orthotic questions that Dr. Feldman will kind of go over. We may have to unmute Dr. Feldman.
All right. Can you hear me all?
Mm-hmm.
Okay. Thank you. Thanks, Sam. Appreciate that. I'll try to keep it quick. I tend to talk a little too much and I tend to get off topic because I always have a lot to say. But I'll start with shoes, and 3 basic questions I always like to ask people is, can a shoe provide support? Is one of them, because everybody that comes into my office talks about how they just got the best shoe and it has tons of support, and why are their feet still hurting? So that would pose a question to me, like, are shoes even necessary? Because I think we have to ask some fundamental questions. We just assume they're necessary, but are they really? And then lastly, which is actually the best shoe, and is there such a thing? So I believe there's a myth of support. We're born with everything that we need. Our bodies are inherently stable structures. Our skeletal system should be able to support us with all the muscles and tendons that we have. And some people have flat feet, some people have high arch feet, some people have regular arch feet. We're all different. Just because you have a flat foot doesn't mean there's anything wrong or broken. And just because you have another extreme doesn't mean there's anything wrong or broken. So I think if we accept these differences, that means you don't necessarily have to support something that doesn't seem like it has a lot of support. So a flat foot is typically considered a flexible foot, but a shoe isn't really what's going to provide the support, as Dr. Kellner alluded to, and as we'll show you in another picture in a minute or so. With footwear, when you go into a shoe store, they're in the business of selling shoes, and there's lots of good shoes out there, of course, and shoe companies are in the business of also selling shoes. So they're going to come out with fancy terms like motion control and anti-pronation. Now, pronation is an important term. We all pronate, we all supinate, which is the opposite of pronation. And what Dr. Kellner was alluding to, it's when we have excessive pronation where problems can occur. And excessive pronation, another way to say that is when we're pronating when we shouldn't be, because again, a pronated foot is a flexible foot. And when we're stepping off of the ground, we really should be on a more stable foot to allow us to propel forward. So not all footwear needs to be supportive. You have to understand the needs that you would have. And then there's traditional versus non-traditional footwear that we're going to touch on in a second. All right, Don. So for years, and when I was in podiatry school, and we learned about the construction of a shoe from the last, which is the bottom of the shoe, the upper, which is the upper material, and the shank, which is what's in the last to stiffen up a shoe. And there's different shapes, and there's all kinds of different features to a shoe. But the newer terminology that I like better are referred to as heel drop and stack height. And to me, these are important terms. So if you're barefoot, you don't have any shoes on, your heel is flat to the earth, and your heel and the ball of your foot are on the exact same level. Traditional shoes are built up on the heel. They basically have a heel lift built into them of about 10 to 12 millimeters, which is about a half an inch. And why they do this, no idea. Somebody thought it was a good idea many years ago, and everybody's just blindly copied it ever since. But children and all of us start out barefoot. And why we change that at some point, it's a really good question that we should be asking over and over and over again. So the heel drop refers to an elevated heel. And so the right-hand side, you can see the top of the shoe pictures has a 0 millimeter drop. That means the heel and the ball of foot are flat to each other. The middle picture has a 20 millimeter stack height. So the thicker sole, the stack height is the elevation of the foot off the earth, and the drop is the pitch from heel to toe. So that middle picture shows a thick stack height, but no heel elevation. So the heel and the ball of the foot are still at the same exact level. Whereas the bottom picture shows a more traditional shoe, a 10 millimeter drop. So the heel is elevated 10 millimeters higher than the ball of the foot, with an intermediate level of thickness or stack height. So you can make shoes really high off the ground and really cushiony. Hoka is a brand that is considered a maximal cushioning shoe, or there are shoes that have very little cushioning to them, which the top picture indicates too. All right, next. So the best shoe, to me, the best shoe is the shoe that fits the shape of your foot, not the shoe, the shoe that you then deform your foot with. So the shoe inherently should fit what your foot looks like. A shoe that helps you maintain postural alignment of the body. Feet are part of the body. The key to having good feet is to have good posture. We talked about this with our Achilles lecture, and any single lecture that has anything to do with anything mechanical in the body, I'm always going to be completely about posture. Posture is your body's ability to offset the effects that gravity has on you, and your feet need to hold up their end of the bargain. So when you have a flat foot, posture is much more important, because the flat foot needs to be, it has a very limited range with which it can function. So a shoe that helps you maintain the best posture is going to be a second feature of a shoe that I love. And then lastly, the lightest shoe available, given the above shape and postural alignment. And essentially what I'm describing is what you were born with. The best shoe that you've ever had and that I've ever had is the same one we're born with. So if you're out there looking for shoes, that's one of the things you look for, something that's as close to the foot as possible. And beyond that, my feeling is shoes are either comfortable or they're not comfortable. Shoes can either be stiff or soft, soft or stiff. And I don't think you have to go looking for a million different features that just add extra weight and extra cost to the shoe. Next. That last little comment was, but are they necessary? I think they're socially acceptable for sure. I don't think it would be all that socially acceptable. Plus, we live in a cold weather environment, so it is kind of hard to not wear shoes. But there's plenty of societies out there that go shoeless, and there's plenty of people that live in the world and even northern environments that never wear shoes. It's crazy, but they do that. So orthotics. So for me, the primary role of an orthotic is to assist with posture, not support the arch. If you look at the pictures below, this ties in very well with what Dr. Kellner was mentioning in terms of heel alignment. That middle picture shows heels that are offset to the leg. So think about the Leaning Tower of Pisa. That middle picture shows the Leaning Tower of Pisa. If you're going to construct a building or a tower, you want the foundation directly under the structure. And your feet need to kind of maintain that foundation so that everything is aligned properly. So the before orthotics picture on the left shows everything offset, and the picture with the after orthotics show how everything can be lined up. And when we do orthotics, that's what our goal is. It's to realign the heel position. Next. Their role also stabilizing foot alignment and rebalancing pressure distribution. So some people can have too much pressure in one part of their foot, so an orthotic can rebalance where that pressure goes, so it evenly distributes it. And then there are conditions that do very well with orthotics, like symptomatic flat foot conditions. So when the flat foot itself causes problems with knees, hips, or back, or in the foot itself, an orthotic can be extremely helpful. If people have poor balance due to a flat foot and that heel malalignment, it's really tough to walk and function and not trip and have strong muscles in the hips and back, and it's difficult to move properly if your feet are not aligned properly. So that's when orthotics can be very helpful. And I'll make a note of, do you need custom versus off-the-shelf orthotics versus something like the Good Feet store and what they provide? I would say if you need an orthotic, you pretty much need a custom orthotic, because again, that heel alignment is the most important thing. Most of the off-the-shelf devices are cushions. They're built up in the arch, or they have a metatarsal pad. And I always relate trying on orthotics to the Pepsi challenge. I don't know if everybody remembers the Pepsi challenge, but Pepsi, when you go to a mall and you try different sodas, you try Coke versus Pepsi, everybody chooses Pepsi in the Pepsi challenge because it's very sweet. But in reality, not too many people actually drink Pepsi because it's too sweet. And so sometimes what feels good right when you put it on, it just feels good. But if something's soft and it's kind of conforming into the arch, it's not going to provide necessarily stability that helps you move better. And after an hour or a couple of days, you're going to realize that and not be as happy as you once were in the store. It's also like standing on a soft sandy beach. It feels really nice on your feet, but try walking on a soft sandy beach. It takes a lot more effort to do that. So orthotics that can realign and reposition your feet just make everything work a whole lot better. And the off-the-shelf or the Good Feet don't do that. And that's not to say that they're not comfortable, because those off-the-shelf inserts or Good Feet, they can be very comfortable, and some people can be very happy with them. But again, if you need an orthotic, you're going to need something that repositions the heel. And soft versus hard, I think a lot of people question, well, do I need something soft or do I need something hard? If you're going to actually change mechanics and change movement and influence function, it needs to be hard. It needs to be firm. Now, it doesn't have to be like concrete or steel, and they could be made with cushion. But when it's firm and it's in the right spot and it's assisting in movement, you shouldn't even feel it in a bad way. And orthotics oftentimes won't work when arches are too flat. Sam showed a picture where the foot was like a pancake on the ground. You try to stick an arch into that, and that's not going to feel very good. Orthotics might help, but they have to have a flat arch. You'd reposition the heel, but keep the arch flat. Other conditions that are difficult to work with orthotics are when people have to wear high heel shoes, or shoes that are just too small for them or don't fit, and that's their choice, or people that are most comfortable barefoot. So some people just try shoe after shoe and insert after insert looking for that greatest thing, and then they come in and they tell me, I'm most comfortable barefoot. And it's like, well, you shouldn't have any support. You should go with less shoe, not more shoe. All right.
Thank you, Dr. Feldman. I'm going to go over a little bit about some x-rays and imaging for those that are here, because when you come to see us in the office or you've been to see someone, we're going to look at an x-ray. And something that I find really helps is I have a normal laminated x-ray, and there's really no normal foot, but I like for people to look at this normal foot and then I throw up their x-ray and they can see the difference. And that's where when you have a flat foot, we're going to look at a few angles, and I want to go too technical, but basically this foot, you can kind of see a nice kind of area of the middle of the foot kind of going down in these two parallel lines. When someone has more of a flatter foot, what you're going to find is that there's going to be a little kind of an off kilter, and it's going to kind of collapse in the middle of the foot. And the problem with this on the x-ray is when someone is very young, you're going to see these differences in the angles, and you're not going to see any problem with that. But your body has to work a lot harder trying to work with this foot. And that's where, like Dr. Kellner showed, there's a tendon that runs along the side that has to do a lot of work, and that can get inflamed or get a tendinitis. But then also on the top of the foot, if something is constantly moving here where it's not supposed to move, it's going to eventually develop arthritis or like little spurring on the top of the foot. And that can develop and get more and more severe, as Dr. Saviet's going to show some other x-rays. So here's an example of of you can kind of see it looks like a little, like a mountain ridge on the top here. A flatter foot, over time, it develops more arthritis in the middle of the foot and then different areas in the foot, and it kind of collapses down. So an x-ray is a really good method to look. And you want to look at the middle of the foot, but you also want to look at the heel position. Normally the heel position should be a little bit further up, kind of tilted upward. And as you get flatter and flatter of a foot, it's going to kind of cause a lot of jamming in the middle of the foot region. And an x-ray is a good way to start, but sometimes, let's say that that tendon hurts you on the inside of your ankle. We can't see a tendon on an x-ray. And a lot of times we'll get an ultrasound or an MRI. Let me just quickly show you. There are some types of angles here. Like there's an angle on the outside of the foot that this line should pretty much be straight. And you can see the whole foot is kind of tilted over this direction. And basically an easy way to look at that is there's this bone right here called the talus. And this line should be equal with this. It should be kind of almost like a ball and socket, where this should be totally aligned, but it's not. So that's a sign of a quite a flat foot. Okay. The tendons can also be affected. Here's just some kind of examples of some tendons in the foot. And what we look at is we look for areas of black and white. Okay. Gray is okay. Like the gray colors are fine. But where you see areas of black, or you see kind of some uptake on the ultrasound, or areas of black here, that a lot of times we'll look at the tendon on your foot and we'll see, wow, there's some inflammation or something going on. Now this isn't in a child. Okay. This is going to be an adult, someone that has a flat foot for some time. And what I typically see is patients that, let's say they do a lot of walking, or they go on vacation and they're wearing a really bad shoe, or they're going to Disney and wearing flip-flops all the time. Their tendons can get very inflamed. They're not going to come in for a real bad foot, like a bony problem, but the tendons can get inflamed. And so giving some type of support can really help them, or doing some type of treatment. We do a lot of shockwave treatment and other types of in certain types of injections that we can put in these areas, not usually cortisone, but other types of injections. And so those are some of the imaging. A lot of times we have to do an MRI or something else. We'll show you some more images in later on. But I want to talk a little bit about bracing. Dr. Feldman, he touched about doing orthotics, and orthotics are great as long as your foot isn't too flat, or as long as they don't push up too much on the bottom of the foot. But I find for a lot of patients that are older, that have that arthritis in their foot, and they are really, really flat, something like this, where everything kind of caves in. You've seen that before. There's two types of braces that we use. This one here on the left there's this little rivet right here. And so basically that rivet allows it to move at the ankle joint. It's called an articulated ankle foot orthotic. So it's an orthotic, it has an orthotic on the bottom here, but it also goes up to the ankle, so it doesn't allow you to collapse in. This is very, very common for an adult that has a very flat foot that's painful, and maybe they're not a very good surgical candidate, or they don't want surgery, or maybe they just want to get some pain relief. And we'll do this, and what you'll see is it'll actually straighten out the foot. Another example is, and there's another brace you can see here on the back. This doesn't have the articulation, and it's called a Gauntlet type of a brace, and it has straps on the other side. It would lace all the way up, kind of like a winter boot, and it would fit into your shoes. But you can see how a foot that's totally collapsed can be corrected just with that type of a brace, but it only works as long as you're wearing the brace. So that's another way of helping to treat flat foot. This is very effective, and usually insurance covers something like this about every 5 years. And so if you have a very flat foot, maybe you've tried an orthotic and it's not enough, that's when you might want to consider an ankle foot orthotic like this. So now we're going to have Dr. Saviet here talk a little bit about some of the surgical treatments for some of these people that may have tried braces, may have tried orthotics, physical therapy, these other things that haven't really helped.
All right, so with a flat foot, generally what we see, you kind of have early changes and late changes, and I just threw a couple x-rays up here of just some generally things we're looking at on x-ray, some particularly terrible foot for a few of those. So early changes are generally soft tissue, where you're going to see tendons and ligaments starting to give out, and over time what happens is when those don't do their job anymore, the bones and the joints start to fail, and that's where you start to see arthritis. So that arthritis is really a main differentiator for us in terms of what procedures we're going to be choosing. But the overarching goals for our surgical corrections, and we do a fair amount of surgical corrections, usually after folks have failed orthotics or failed a brace or failed lifestyle modifications and it's just not working for them anymore. Our goal, like any surgical thing, is to any surgical correction is to create a stable, pain-free foot that can be you can live your life on and do your daily activities in a shoe. Oftentimes that does require an orthotic, so we take a foot that is just an absolute disaster and not good under any circumstances with a brace or with an orthotic at all, and we make it a much more stable foot where you can walk around your house a little bit. You can go to the bathroom in the middle of the night without an orthotic and you're fine, but under normal circumstances you're wearing an orthotic when you're out and about or walking around Disneyland. One of the main surgical goals we also try to aim for is try to eliminate the need for multiple surgeries and a protracted recovery. In some cases, we're sabotaged by what we're working with. So sometimes if you're trying to make chicken soup from chicken poop sometimes, so you sometimes have to go back to the OR and live to fight another day where you go back and do more work on sort of a staged procedure. That's not uncommon. And obviously our goals are to improve patient function. We want to take a painful foot and get it to do its job. And different patients have different demands. A collegiate athlete who ruptures their posterior tibial tendon who wants to be running 5Ks is different than the 70-year-old person who has a painful arthritic flat foot. We would do very different procedures for those two people. All right, next slide here. So just this is sort of one of the things that I'm big on is this tripod of the foot. So if you look on the left side, everyone kind of knows what a tripod looks like. And then this view of the left, we're going to use the left foot going forward. So if you look at the line that you could draw through the middle of the heel, that's going to be one arm of the tripod. The fifth metatarsal is going to be off to the left side. That's one leg of the tripod. And then just behind the big toe is the first metatarsal, and that's the third leg of this tripod. And I know it's confusing because I use the right foot on the other side there, but that shows the images you've seen of overpronation, a neutral foot, and a supinated foot, so a high arch foot. So we can go to the next slide here. I made this easy, right? I just put a tripod right on the back part of the foot, and I'm going to try to explain how your foot is like a tripod here. So each of those arms is able to move in a different direction. So if you take that tripod arm that goes right through the middle of the heel and you move that towards the pinky toe, that's going to make the whole apparatus unstable here. So we can go to the next slide there, Don. And then this is going to be animated. So we're going to take that arm in the middle of the heel and we're going to shift that a little bit to the left. So it should animate for us. Perfect. Put another one on there. Great. So now we shift that to the left. And what that's going to do is it's going to change the forces of gravity under the heel. It's going to push it lateral to the weight-bearing axis of the foot. When you do that, I'm going to hit the next one for me if you could. So we shifted it about that far. Sometimes it's as little as a centimeter. That's going to cause this whole tripod to tip because we can't make the other legs of this tripod any longer. They're not moving necessarily. Another thing that we can deal with is not just that the heel is unstable and shifting, is that the first metatarsal, that segment of the foot called the medial column, can also be unstable. So if we're going to shift that arm upwards a little bit, we're going to make it unstable and it's going to float up in the air. And this one's really obvious because now when we put weight on that tripod, it's going to tip all the way over again. So we've raised it up a little bit, we made it unstable, the whole apparatus is going to tip. And that's going to create that pronation movement and motion. So we can go to the next ones here. So the goals we're trying to treat are really to get that tripod stable in whatever way we really need to. It's the same, essentially the same function for orthotics and for bracing as well. Surgical options are really dependent on the foot that's in front of us, your activity level, and your age. So the older you are and the more arthritic your foot, and the less reducible in terms of being able to put the joints back where they belong, the more likely you are to end up with joint fusion. So we sort of sacrifice some of these joints to really put your foot in a perfect position. Do you lose a little bit of mobility in your foot? Yes, but you're trading that for a predominantly pain-free foot under normal circumstances. A lot of the times folks have too much motion and that's what caused the issue in the first place. If you're a younger athletic person with reducible deformity so we can put it back where it belongs, a lot of the time we can do joint sparing procedures where we can put in a bone graft that's going to change the alignment of your foot, or we can cut and shift bones, put them in place with screws or plates. Those work very well for people who have reducible deformity. A lot of the time, there are also soft tissue procedures, whether we're repairing ligaments or tightening ligaments, or we're transferring a tendon to repair one that's no longer functioning well, or we're advancing a tendon. All of those are very useful procedures. However, if your foot's bad enough that you have caused that soft tissue to fail, it is a fool's errand to only do a soft tissue procedure, unless you cut yourself with a piece of sharp metal and lacerate a tendon. If your tendon has failed because it's been overworked, to just directly repair it and not support it with bony work to correct the structure of the foot, you're asking sort of repaired tissue to do the job of healthy normal tissue, and it's not going to be able to do that. It's just going to fail. And then there are other surgical options for kids that are different than adults. So I'll just we'll blow through some quick surgical corrections here. This is one that's very common for me to do. You can see on the image on the bottom left that the talus is pointing down towards the ground, and the first metatarsal is kind of floating up in the air. And if you look at the images on the top right, you can see that his talus and his calcaneus, those two bones in the back part of the foot, are very divergent. Really, the talus should sit on top of the calcaneus. I know I'm talking about this and not being able to point at them, so sorry about that. But the ultimate end result, you can see surgically, we put the talus, we propped it back up where it belongs, and we fused it to the calcaneus. We plantar flexed, basically stabilized that arm of the first metatarsal for that part of the tripod. And so we fixed those two arms of the tripod, and that gave this guy a lovely, stable foot that he's able to do everything he wants to do now. So that's what a single joint fusion looks like. And he had pain in that subtalar joint. So he got a cortisone injection, and that basically proved that that joint needed to be fused, because when I gave him the cortisone injection back there, all of his pain went away. So on the next image, this is someone who had more of an arthritic foot. So their subtalar joint in the back is much more arthritic. You can see there's a bunch of bone chunks in there that don't belong. You can't see through there quite as well. One joint forward at what's called the talonavicular joint, they also had a bunch of arthritis that was developing. You can see the bone spurs at the top of the joint and the poor alignment there. So ultimately, this person got what's called a double arthrodesis, where we fused the subtalar joint and the talonavicular joint. And also, I did my standard medial column procedure where I fused that metatarsal cuneiform joint there. I absolutely love that procedure. All right, we'll go to the next one. So this is an even worse foot, which ended up with what's called a triple arthrodesis, where we just add in another joint called the calcaneocuboid joint. This was a guy who had failed an articulating ankle-foot orthoses brace for over a year. He has one on his left foot that does totally fine, but this right foot just became so bad that he needed something done to it, and he's happy as a clam with this fusion of his rear foot. We did some Achilles work on him. This is not the same person, but depending on the joint level where the deformity is really determines where we do our fusions, or where we attack the deformity to correct it. So this person on the left has a horribly arthritic ankle, and it's not comfortable under normal circumstances. She's actually, again, happy as a clam in a brace that locks up her ankle joint. This image on the right is an ankle fusion for someone who had just arthritis in their ankle joint. He didn't have any deformity, so I didn't put his pre-op x-rays in there. He had an old ankle fracture that needed to be fused. Then there's a couple other deformities. One of these, this is called a transverse plane flat foot, where there's no real deformity in the back part of the foot. If you look at those pre-op images, they're totally lined up okay. But when you look at that foot from the top down, you can see that whole thing is swung off into right field there, and it's horribly arthritic through there. So the way we corrected that was we took a big wedge out. You kind of imagine coming in from the side, you take a pie wedge out, and then we close that all down with a big plate and a bunch of screws through there. That was a great correction for her. We ended up doing some toe corrections on her later. So that was a staged procedure for her. This was a woman who didn't have any arthritis at all. She had a rupture of her posterior tibial tendon, which is that big tendon that holds up the arch. It failed because she had a flat foot. So what we did, instead of fusing her joint, we did a bone cut to her heel, and we shifted her heel. We moved that arm of the tripod closer to the first metatarsal. We basically shifted it towards the midline of the body, which eliminated some of that deforming force. And then we transferred in a tendon. We stole what's called the flexor digitorum longus tendon, and we transferred it into place to support that tendon that had failed. And she's been doing great with this. She's got an orthotic in there. I did not do her bunion. Somebody did her bunion when she was about 20, and she's in her 40s now. Would never do that. This is another one of those joint sparing procedures where this foot was swung off to the side, but without arthritis. So what we do is we go to the back part of the foot, we cut the heel bone, and we kind of crank that open. So the whole foot kind of rotates around over towards the big toe. In the process of doing that, it unmasks the fact that this woman had a bunion as well. So I kind of got to do a twofer here where I corrected her bunion and was able to stabilize that arm of the tripod there and really gave her a nice foot long term. She's an avid golfer, and if I had fused her joints, if I'd fused the back part of her foot, she would have been pretty upset with me. I probably would have taken 30 or 40 yards off her drive. She couldn't pronate and supinate. All right, and our next one, I took some of her hardware out. In terms of, I can't even see the top of my slide. We almost never do solo procedures for joint sparing stuff and for soft tissue work. There's almost always bone work that supports it. It always corresponds to the level of the deformity. So if it's in the middle of the foot, we repair it there. If it's in the ankle, we repair it there. And a lot of the times we'll just kind of use a soft tissue procedure to reduce forces. So what Dr. Kellner and Dr. Feldman were talking about earlier with that tightness to the calf, that can be a significant deforming force to the middle part of the foot. So we'll sometimes do either an Achilles tendon lengthening or a calf lengthening to reduce the forces through the middle part of the foot there. This image there on the bottom is just of a ligament repair called the deltoid ligament and the spring ligament too. Those are fun. I've done a couple of those. And I think we got this. This is one of this is a misadventure by someone else. They did an okay job, but knowing the tripod philosophy, you can see that they corrected a lot of the flat foot in the heel, but on those lateral x-rays, you can see that that first ray is way up in the air and it needs to be dense. Just post-op one down up top. There you go. That's way up in the air. So her big toe joint is going to jam, and she's still going to have a collapsing flat foot through the middle part of her foot because that's not down and stable where it belongs. I think the last thing I have is just some pediatric discussion. In terms of when to operate on a child, I almost always have them in an orthotic first. Some kids do outgrow flat feet, but if it's symptomatic, that starts to become something that we get concerned about. If it hurts, that's an issue. So I have something called an amusement park test where I say if you went to Disney World with your family and you were 2 hours in at the happiest place on earth, if the kid's complaining and wants to go home because their legs are tired and their feet hurt, that's a bad sign. That's a really bad sign. In terms of procedures for kids, we're always looking to avoid joint fusions until they reach skeletal maturity. Have I had joints fused on 16 and 17-year-olds? Yeah, you betcha. But we try to avoid that as much as possible. We want them to have a foot that functions as normally as possible. Coalitions, we really want to resect those as early as we identify them, but a lot of times we don't even know they're there until kids start to skeletally mature. So sometimes around age 11, sometimes as late as age like 16 or 17 is when they start to really solidify to the point where they don't move anymore and it becomes obvious. There's another procedure for kids, subtalar joint implant, that you can sometimes use. It is for very limited types of flat feet. So if a doctor recommends this as a flat foot surgery, I usually recommend that the patient or the parent ask that doctor what other flat foot surgeries they do, because for some guys out in the world, all they have is a hammer, which means the whole world looks like a nail to them. So they're just gonna do the same, hammer this implant into kids, and that's not always right. It corrects in the wrong plane for a lot of these feet, and causes more harm than good a lot of the time. It has its role, but it's a very limited role, in my opinion. So that's sort of the pediatric situation.
Great. There was one, we're going to start with the questions now. Thank you, Dr. Saviet. I guess this was, you may have addressed it. What is a good determination that one needs a surgical solution? I think you said it's the, what is it called? The amusement park test, right?
Yeah, certainly for a kid, I think that's a great, just, a rough estimate. Sometimes your hands are forced. Like, I have a girl who's a gymnast, and while she was doing high level gymnastics, I beat myself up about whether I should be fixing her flat feet because they were causing her issues. But it really only mattered when she was doing gymnastics, and I kind of waited it out, and she quit gymnastics about a year later. So I felt pretty good about the fact that she's completely asymptomatic in her orthotics, and I did not do a surgical correction on her because she didn't need it. She's totally controlled in her orthotics, and she no longer has that irritating factor of the gymnastics.
Perfect. If people have more questions, tell us about this here.
Oh, all right. So I put this in here because flat foot surgery is a lot like jazz music. There are some surgeries that are out there that, all of us as surgeons, we know our instrument, we know our scales, and we can play the music that's on the page. However, jazz music requires a certain amount of improvisation. You need to respond to what the other musicians are doing, the stuff they're playing, the stuff they're not playing. In many ways, to me, a flat foot surgery, I kind of go into there thinking that I have about 6 to 8 different options a lot of the time. So I'll kind of do the most corrective one first, and then I see what their foot does, and then I react to that and do a different thing. So it's a little bit like jazz music, where you kind of know where you're going, your instrument, and you're just going to react to what the other players are doing throughout the entirety of the surgical correction, knowing what the end game is to get a stable, shoeable, structurally functional foot.
Great. Thank you, Dr. Saviet. I want to thank for everyone that stayed to this point. We're going to start answering your questions now. And we got a lot of good questions when people registered. So thank you for doing that. If you have other ones that we didn't address, you can write them. But let's, a lot of kids questions here. So let's start here. As we age, do feet get flatter? I used to have very high arches, making it impossible to get into many shoes. And now as I got older, they got flatter. Maybe Dr. Kellner, you want to answer that one?
Sure. Yes, as especially in the cases of that posterior tibial tendon, if we recall to that slide, as that tendon gets weaker and dysfunctions, that is a progressive deformity, and it can get worse. And whether or not your feet gets flatter or your symptoms get worse, it could be a number of things. So that's one instance where it, yes, certainly can become flatter, or if you can take the necessary precautions and take care of it with orthotics, bracing, physical therapy, strengthening, you're able to prevent it too. So
Dr. Feldman, talk a little bit about this. When every time they have a baby, these patients, they come and say their feet got bigger. Is that something you see in your practice?
Oh yeah. So gravity over time, as we age, we get shorter. And as we get shorter, we still have the same number of bones. Our joints kind of get a little compressed, and our feet get a little flatter and a little wider. When women have babies, there's a hormone released right before the baby's about to come out. It's called oxytocin, and that helps the pelvis relax and open up a little bit to allow the baby to come through. But it doesn't just work on the pelvis. It works on every single joint in the body. So with women as they go through childbirth, they pretty much go up about at least a half size each baby. And and the more babies, the more sizes their feet go up. Plus, if you start out with an arch like that, and then over time it flattens, it's the same. The bones, if you take them out and lay them on the table, they'll measure the same. But if they're oriented differently, you're going to have a relative lengthening and widening of the foot. And I'm just going to add one thing to that with shoes. When I ask people, what size shoes do you wear? And they say a size 10. Well, how long have you been in a size 10? Oh, I've been in a size 10 for 40 years. And then I put their foot on the sock liner of that shoe and watch every single toe hang out over the side of the shoe. I tell them that you're probably a size 13 at this point, and you've been stuffing your size 13 into that size 10 for maybe 30 years, and you just got used to it. So the answer to that question is yes.
They do get bigger. Yeah, you're not the same. Yeah, you're not the same size forever. Should we do anything, Dr. Saviet, to correct flat feet in children? Do you need to do something? There's a couple of kid questions here. Does every kid need orthotics? Does every kid need a surgery? Not a surgery, but
no, really, it comes down to symptomatic, right? Is it symptomatic? So there are plenty of people, even high-level professional athletes, for example, in the NBA, that have flat feet. They look like rowboats. They got these flat feet that are size 18, flat bottom boats. They don't go anywhere. So, those were kids that had flat feet, and they're obviously not hampered by it. They're competing at a world and international level. So, no, you don't have to do anything about flat feet if they're asymptomatic to an extent. Some kids are those abnormal forces may cause them to develop arthritis. Should every kid with flat feet probably be seen by someone who knows what they're doing with flat feet in terms of like a medical professional? Yeah, probably. If you're concerned enough to ask the question, it's worth going to see someone to rule it out. But if your kid's totally asymptomatic and they're active doing normal kid things, then definitely you're probably okay to maybe not do anything. If your kid's asymptomatic because they sit in a beanbag chair and play Call of Duty all day, well, that doesn't count. If you're avoiding activities to make your feet not hurt, and when somebody asks, "Oh, your feet don't hurt, do they?" And "Oh no, my feet don't hurt, but I sit in a beanbag chair all day." Yeah, your feet aren't going to hurt if you're not putting any forces on them.
I think that's true, Dr. Saviet. I think a lot of the patients come in the kids. We have kind of an epidemic with like obesity as well, and a lot of these kids, it's not their fault. They just don't want to be active because they say, "Well, I just don't like to do anything," or "I don't like sports." But a lot of times it's because their feet hurt. It might be flat feet, could be something else, could be a coalition, could be something else. So if you have a 14-year-old child, that if you're concerned enough to ask me this question, you should probably at least come in for an evaluation. That would be the recommendation. Now, younger than that, a year, my son's 20 months. It's been slowly advancing his walking. His feet seem very flat, which Dr. Feldman talked about this a little before. It seems to be improving and he walks more and more, but is there anything that should be done or any concerns? Dr. Feldman, 20-month-old kid, do they have flat feet?
Yeah, kids have flat feet until about 3 years of age, typically. The best thing that this person can do is just not put shoes on their feet. If you put a supportive or a stiff, let me correct myself here. If you put a stiff sole on that foot, that's going to be like a crutch, and the walking might actually get a little bit better, but at the expense of helping the muscles and tendons develop appropriately. So yeah, it's perfectly normal for a 20-month-old up to a 36-month-old, give or take, to have flat feet. It takes a while to develop strength. Plus the bodies continue to grow. So you develop strength at a size of 2 years old. And then now you grow quite a bit relative to where you're at for another year or two. And then the muscles and tendons have to keep playing catch up. So there's this constant sort of battle between the body growing and the feet not strong enough to support the new body, and the muscles and tendons have to keep getting stronger and stronger. You stuff them into shoes sometimes, it weakens everything. And as far as, kind of circling back with orthotics, when it's symptomatic, when, kids don't always complain of pain, they just sit on the sideline. At Disney World, they'll sit on the bench and just say, "No, I'm good. I'd rather just sit here instead of running around and playing with my friends." So kids mostly don't complain of pain. They just don't engage, or they get tired very easily.
Mm-hmm. I think you answered this one as well. Are orthotics indicated for growing? If my kid isn't done growing, should they still have orthotics, or when would you recommend orthotics for them?
when it affects movement. Again, when they're fatigued, when their legs are fatigued, if they're having other issues, if you see, their knees knocking together, if their hips are very unstable, if they can't, if they look uncoordinated running around and they stay uncoordinated. Now, there is a time when, we don't grow like in an even manner. Our feet and our legs grow first, and then the rest of the body grows, and we keep sort of playing catch up until we're fully grown. So sometimes there's this little period of time where there's a little uncoordination because you got a small body with big feet. But then once the body catches up to the size of the feet, if you remain uncoordinated, then a lot of times orthotics would be very helpful for that. Or if the flat foot is interfering with their ability to perform, orthotics can be really helpful for that.
Perfect. Just this was an interesting question. This patient, they said they had flat feet and they had some muscle cramps and spasms in the foot and up the legs and calves. They tried magnesium, massaging, some magnesium gel and ice. Can there be calf pain from really flat feet? Any thoughts here, guys? I don't know who wants to take this one.
Yeah, absolutely.
I'll keep talking.
You got it if you want.
Huh?
You got it.
You want to talk? Yeah, so when you have flat feet, your muscles that attach to the feet have to work harder.
Mm-hmm.
And the harder they work, the more fatigued they're going to get, and the more likely they are to cramp if you're overworking them. Magnesium is fine. Maybe it's something that magnesium is an electrolyte, a salt, and it's possible that your muscles are cramping because you're somewhat relatively dehydrated. But a lot of times it's just the muscles being overworked and not doing enough to help them to relax, recover. Moving more, being more active is good. Foam rolling, massage. I mean, maybe the rubbing, the actual act of rubbing is what's helping the cramps as opposed to the gel and the ice. But it's not a bad thing to take supplements.
Yeah. Orthotics, you've been covering a lot of these, Dr. Feldman. When should they be updated? Is it every 2 years, 5 years? We see some patients come and have them 20 years.
Again, it just depends on how they look. Some people are really hard on orthotics and they break down, and they found that orthotics really helped them out a lot. So if the orthotic is cracked, then they need to be updated. Typically, an orthotic is going to last a minimum of 5 years. If it lasts less than 5 years, then somebody's really hard on them, and we might need to beef them up a little bit.
Mm-hmm.
But if you're not very active and you just wear them for everyday life, walking around, there's, like you said, there's people that have them 20 plus years. Then on the other hand, there's people that come in with orthotics that are 20 to 30 years old, and they were really not that good 20 to 30 years ago. So they're still not going to be that good. And in those conditions, if they're not controlling heel position and they're not helping posture, then we might want to update them. And then a lot of people think that because the top of the orthotic is ripped or torn or ratty looking, that the orthotic is broken and they need a new one, which is also not the case, because sometimes the shell of the orthotic is really good and you just need to recover it or resurface it.
I've made a comment that the material that the orthotic is made out of, particularly the shell, is important. If you use a material that doesn't have much of what's called creep, then the shell is going to maintain its alignment over an extended period of time, which is why we use a lot of carbon fiber graphite orthotics in our office. Regular polypropylene or any of those other plastics do lose their shape over time. And I think hitting it with the heat gun to mold it back into shape is just a ridiculous proposition. If it was formed appropriately and then you're just going to go heat it up in the back room and push on it a little bit, I think that's just silly.
Yeah. I think maybe the last one here. Should shoes have orthotics? Does everyone need orthotics in their footbeds of children and adults? I think we've addressed this. Only people that are asymptomatic or have they get tired when they're walking or any other types of heel position. So we kind of address that.